Today we are going to discuss about the complement mediated hemolytic uremic syndrome. The complement mediated hemolytic uremic syndrome is also called the atypical hemolytic uremic syndrome. More than 50% of the hemolytic uremic syndrome are usually complement mediated. So we are discussing the complement mediated hemolytic uremic syndrome, and more than 15% of the cases are usually atypical hemolytic uremic syndrome or complement mediated hemolytic uremic syndrome. When we talk about the pathogenesis, basically what happens, the complement system is part of our innate immunity system. The complement system is part of our innate immunity system, and basically this system is responsible for the defense against the infection and for the inflammatory homeostasis. So to maintain the inflammatory homeostasis and to defend the infection, this complement is very much important. When we talk about this system, there are three arms of this system. Number one, classical pathway. Number two, alternative pathway. And number three, the lactic pathway. So if we talk about the complement mediated hemolytic uremic syndrome, this alternative pathway is basically disturbed, and this alternative pathway becomes the pathological, and that gives the disease which we call the complement mediated hemolytic uremic syndrome. So mainly the alternative pathway of the complement system is usually responsible, becomes pathological, and causes the disease. Now, on the basis of this background, we usually divide this disease in two kinds or two parts. Number one is called the hereditary. Hereditary means when there is a mutation in complement regulatory protein. Actually what happens, this complement is usually regulated by some kind of the proteins, and these proteins, if are mutated, if there is a mutation in these regulatory proteins, the disease occurs. And what are these proteins? These regulatory proteins may be the complement factor H, the complement factor I, the complement factor B, thrombomodulin, and there may be the MCP. So these are the regulatory proteins which control the complement system, and if there is a mutation in this system, usually disease occurs. And sometimes this often requires another hit, and the hit may be the infection, and maybe the pregnancy. So if we discuss about the hereditary, so there must be the mutation, and mutation related to the regulatory protein. And what are these regulatory protein? The regulatory protein may be the complement factor H, complement factor I, complement factor B, thrombomodulin, and MCP. Now the second one is the acquired. Acquired means there are antibody formation to these regulatory proteins, especially the complement factor H and the complement factor B. When there is antibody formation against this regulatory protein, so this is called the acquired. So we are discussing the complement mediated hemolytic syndrome, and this may be the hereditary and this may be the acquired. If we talk about the epidemiology of the disease, so usually 7 per million of the cases can occur. If we talk about the epidemiology of the disease, 7 per million cases can occur, but it can occur also sporadically. So sporadically, without family history, this can occur, and it can occur with family history, and 7 cases per million can occur. Now, what is the age of onset? Usually variable. It may be the less than 1 year to it may be the less than 1 to more than 20 years, and usually 60% were usually 60% were adult onset. So if we talk about the age of the onset, this is variable, less than 1 to more than 20 years, and 60% were adult onset. Adult progress to ESRD in 46% of the cases, and death can occur in 6.7% of the cases of the disease. Actually, what happens, there is ischemic injury to the organs, and ischemic injury especially to the kidney, and the most common ischemic injury to the kidney, and ischemic injury can be to the lungs, can to the GI tract, and ischemic injury can be to there may be the formation of the gangrene of the fingers and toes. So the most common ischemic injury is to the kidney. So now we discuss the investigations or labs, what we find in the labs, if we do the investigation, we usually found the microangiopathic hemolytic anemia, and the investigation related to the microangiopathic hemolytic anemia, and we can do the antibodies against the complement, and we can do the complement we can check the complement mutations, but we are supposed to check this in special labs. So if there is no facility, we can't check the mutations or antibodies against the complements. But if the complements are normal, it does not exclude the disease. So if we find the complements, and it doesn't mean the disease is not complemented hemolytic uremic syndrome. So we are supposed to take care of this. Now, what is the diagnosis of exclusion? If we talk about the diagnosis of exclusion, then we are supposed to exclude the Shiga-like toxin-associated hemolytic uremic syndrome. We are supposed to rule out the thrombocytopenic purpura (TTP). Usually, when we diagnose the TTP, we are supposed to be positive on ADAMTS13 factor. So if ADAMTS13 is negative, then it is not TTP. So these are the diagnosis of exclusion. Now, what about the kidney biopsy? If we do the kidney biopsy, what we find? In kidney biopsy, usually we find the thrombotic microangiopathy. Thrombotic microangiopathy cannot distinguish from other causes. So we are supposed to see the light microscopy, and in light microscopy we see the mesangiolisis, we see the vascular onion skinning, or plus minus thrombi may be there. If we see the immunofluorescence, in immunofluorescence, usually fibrin staining thrombi may be there, and no immunoglobulins or complements. In electron microscopy, we usually found endothelial cell swelling. In electron microscopy, we find the endothelial cell swelling and subendothelial electron lucent spaces. So thrombotic microangiopathy does not exclude the other causes of the disease. So in light microscopy, we find usually the mesangiolisis, and there is the vascular onion thinning, maybe there, plus minus thrombi. In immunofluorescence, usually fibrin staining, and fibrin staining thrombi may be there, and there may be no immunoglobulin and complements. In electron microscopy, we find the endothelial cell swelling, and there may be the subendothelial electron lucent space. If we talk about the treatment, we usually give the anti-C5 monoclonal antibody. This is efficacious in 80% of the cases. In whom the plaques, who are the plaques dependent or refractory to the plaques or plasmapheresis. So the patient who are refractory to the plasmapheresis or plaques, we are supposed to give the anti-C5 monoclonal antibodies. But before giving the monoclonal antibody, anti-C5 monoclonal antibody, we are supposed to give the vaccination against meningococcal, pneumococcal, and influenza. So this is the treatment we usually follow. Other treatment may be the immunosuppression like cyclophosphamide, maybe the plasma exchange like plasmapheresis. So monoclonal antibody, plasmapheresis, and cyclophosphamide may be the part of the treatment. Now, what about the transplant? Before eculizumab's use, the recurrence of the disease was 80%, and especially with CFH mutation, the recurrence was 80% before the eculizumab's use. If recurrence in allograft, then if there is a recurrence in allograft, then we are supposed to give eculizumab plus minus plasmapheresis. So eculizumab plus minus plasmapheresis we are supposed to give if there is recurrence in allograft. So this is about the treatment of the disease. So this is the complement mediated hemolytic uremic syndrome. Thank you.